You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and a Blood Cancer United volunteer. And I want to just say to all of you how exciting it is. This is our second podcast. We've actually done 104, but is our second as Blood Cancer United. But I want to thank all of you for joining us on this second episode, which I think will be really interesting and informative. Today, we're going to be talking about measurable residual disease, MRD, including available assays, clinical interpretation and applications, its role in trials, patient communication, testing access, insurance coverage, and educational resources for healthcare professionals and patients. And we're delighted to be joined by Dr. Rahul Banerjee, who's an assistant professor at the Fred Hutchinson Cancer Center in Seattle. Rahul, thanks for joining us.
Thank you, Ken. It's a pleasure to be here and to be supporting Blood Cancer United. To be podcast number 2 with the new name is very exciting.
Thank you. So I'd love to hear a little bit about you. What led you to this career in blood cancers and at the Hutch?
Yeah, absolutely. So I trained at Penn on the East Coast and then UCSF on the West Coast. So I've done both coasts. During residency, it was the early days of CAR T therapy. Back then, I joke that appropriately, the patients receiving investigational CAR T therapies and the residents were basically never allowed to touch them, except our medical ICU was entirely teaching. So basically, we would never be allowed to come anywhere near those patients unless they were on death's door. And then all of a sudden, they were our responsibility. Which at that time, I was like, I never want to do this ever again. Wow. Somehow, the path came back to me during fellowship. A lot of my mentors were in transplant, CAR T, multiple myeloma, which is my specialty, and CAR T was a big part of that. And so, upon graduating from UCSF, I took a job here on the faculty at Fred Hutchinson Seattle, and MRD kind of came with me. At UCSF, we had one attending, Jeff Wolf, is and remains a very big proponent of MRD and multiple myeloma. He was well ahead of the curve, and I kind of got that passion from him, and I brought some of it here to Seattle, and it's been nice to see. The field has evolved. Certainly in other disciplines, in leukemia, they've been using MRD for a while with blinatumomab and transplant. And in the lymphoma CLL community, have been using MRD. Myeloma, I would say, went from the back of the pack to the front of the pack now because we're using it as an endpoint in our trials, which I'm happy to see.
Yeah, thank you for sharing all that. So let's dig right in. If you can, give us the basics of MRD, but along with that, the nuts and bolts. I'm in clinical practice in the community, but how do we access that and how do we use it?
So the first question that always comes up is, what does MRD even stand for, right? So depending on where you look, you'll see minimal residual disease, molecular residual disease, or what I tend to use, measurable residual disease. I'm okay with 2 of the 3, but not the 3. I will say, just in terms of semantics, I think that's an important point as all of you discuss this with patients. The FDA still says minimal residual disease. They tend to be slow to change their nomenclature. I don't like that word, right? Because first, minimal residual disease is kind of a binary, like either it's there or it's not. And as we'll talk about, the devil's in the details of an MRD. What assay did you use? What sensitivity does it reach? Can it reach 1 in 100,000 cells, 1 in a million cells, etc.? Is a big distinction. And measurable residual disease is a much better way of looking at that particular point. And the other part is, I think just the word minimal residual disease makes it seem like it's not a big deal. And in some scenarios, it is truly not a big deal. But for example, in BALL, the decision about blinatumomab and allo transplant with a curative potential, etc., a lot of that is predicated on MRD status, right? And it's no longer a minimal thing. It's actually a very big deal for patients. And so I think when I talk about what it stands for, I think the biggest part is that it's measurable residual disease. It's residual, it's disease, that part's easy, but again, devil in the details of how you check for it. To your point about how is it actually checked just logistically, we can go into it in more detail, but I'm going to focus really on blood cancers, obviously, for this audience. I might sneak into multiple myeloma specific soliloquies here and there, because again, that's my area of specialty, but I'll talk about everything.
Sure.
Generally can be checked off the bone marrow or off the blood. The gold standard would obviously be to check everything off the blood every single time. And for example, in CLL, it often is possible to check for undetectable MRD from the blood just because CLL, by its nature, those cells are always in the blood. For leukemia and multiple myeloma in particular, we often do have to look in the bone marrow just because the sensitivity of the bone marrow is higher, just because there's that old saying when they asked the robber, why do you rob banks? And he was like, that's where the money is.
That's where
Why
the
check
money is. Yep.
MRD in the bone marrow? That's where
Yep.
the cells are.
Yep.
We're working on that. I would love for a world, and certainly many companies around the world are looking at trying to disease-specific manners in leukemia besides CLL, in lymphoma, in multiple myeloma, really check for MRD from the blood, meaning looking for the cells. Again, the question is the sensitivity. Will you have enough of it? So most times for the gold standard in many malignancies, it is off the bone marrow. Technically, in multiple myeloma, some of you may hear about platforms that offer an MRD type approach to things where they actually look for very low levels of the monoclonal protein of the M spike. That's very specific to multiple myeloma. I actually would not really call that MRD because that's not looking for the cells, it's looking for the proteins that the cells produce. And
Right.
the proteins can
Yes.
lag behind. So that's what I would say. And then the final thing, just to say that we've talked about it, technically, the first disease in the world to use MRD was actually CML. We don't really talk about
Yes.
it that much because we take it for granted. But
Yes.
obviously, BCR-ABL testing, typically done off the blood, that was the original MRD test because we happen to have a gene that we could test for. So that's in the same category. That obviously is almost always off the blood.
Something that's interested me is, and I'll call it not measurable disease, that probably is a threshold under which we can't detect a cancer being there. And I wonder about that. So, is there a level, or even patients that have measurable residual disease, where the cancer actually is sort of in stasis or held at bay? Let me give an example. We look at women with breast cancer, who go 15 years and then recur. Well, the cancer was there, not measurable. So, what can you say about that status? Patients where it's there, but you can't measure it. How does that happen?
It's an excellent question. And that's why this is so difficult for patients and physicians and guideline groups and regulatory agencies to talk about. So I think a couple scenarios can apply there. So one would be truly that the disease was there on the sample you took, but below your level of detection. And two, you looked in the wrong spot. Not in a bad way, just bad luck. The disease was somewhere else. So I think
Right.
talking about each of them in tandem. So I think point number one, as you said, every test has this level of sensitivity. And that applies even for the CML tests, for example. That
Right.
same principle applies. Typically, I'll go into multiple myeloma for a second, just as an example. Internationally, we use 10 to the minus 5. So 1 out of 100,000 cells is our level of detection. And if it's below that, we call someone MRD negative. It leads to some interesting clinic discussions when I have patients where the report in the US, we often have access to next generation sequencing assay, clonoSEQ by the Adaptive company, that can reach 10 to the minus 6.
Mhm.
And, someone that was 1 out of a million, and I have patients who are 4 out of a million, and I call them MRD negative, and they're like, well, the report says MRD positive, and I was like, well, it's
Yeah.
complicated. And part of that is because there are many different ways to test for MRD. Around the world, many centers use next generation flow cytometry, which cannot always go below 10 to the minus 5. So that's a myeloma example. In AML, I talked about ALL briefly earlier with blinatumomab, but in AML, there really is no next generation sequencing platform really at all, apart from rare scenarios like FLT3 positivity. So for those patients, we typically use flow cytometry from the bone marrow, and there you can typically hit 10 to the minus 4 or so, which is 1 out of 10,000. And so it's very possible, to your point, that patients can have levels of disease that are either detectable but below the level that we are concerned about, or below the level that we even can check for. That is very possible.
Yeah.
The other part, just to talk it through, is part of the allure of blood-based MRD assays, if we can get them reliably, is not just that they're much more convenient for the patient, but also obviously they kind of capture the entire body's worth of disease at once, if that makes sense.
True. True.
For
Yes, it
bone marrow,
does.
for multiple myeloma, as an example, I have had scenarios where you do the bone marrow biopsy and it's MRD negative, and it's wonderful, but you do it at the same time. In my mind, to call someone MRD negative multiple myeloma, a whole body MRI is required. Why? Because if you do the whole body MRI, you might see clear as day that, yes, the hip bones, we did the bone marrow biopsy, are clear, but look, there's clearly something growing in this bone or that other bone that you're not capturing. And that's a problem. And it's not an easily fixable problem. Even if I asked a patient to do two separate bone marrow biopsies, they would hate me for it. And truly, I don't know that it would fix it because inherently many diseases are somewhat patchy. And so I think in the scenario, and I have had this happen, for example, for patients with multiple myeloma, where they are MRD negative following CAR T therapy, but then they relapse 3-6 months later. Often in my practice, it's the patients who have visceral extramedullary disease. So kind of myeloma growing outside of the bone, or in leukemia, the example would be a chloroma, something growing outside of the bone marrow, and it may be harder for the CAR T cells to get in there and harder to see what's going on. And that may be a nidus of relapse. So I agree. What you're getting at is, does MRD negativity equal cure? It doesn't. And just finally, to talk to your other point, because you asked a really good two-part question. You asked, are there some patients who are MRD positive where the disease is in stasis? And the answer is absolutely. And that makes this even more complicated. This is probably more of a myeloma problem than in other malignancies. Because, for example, in leukemia and AML or ALL, any cancer is bad. Because myeloma exists on the spectrum from MGUS to smoldering myeloma to active myeloma. Just as an example, if you were to check MRD on a patient with MGUS, they'd be MRD positive. That sounds obvious, but in real time, something you're like, wait, what? They're MRD positive? Of course they are. They have abnormal plasma cells there, and the test is just looking for an abnormal clone. So I have had some patients who are MRD positive their whole life. They never achieve MRD negativity, and it stresses them out because you hear all this stuff about MRD. But in myeloma in particular, MRD positivity, some of those patients actually have an MGUS-like phenotype where the cells that are capable of chewing into the bones are gone, and you have this precancerous core left behind. I can't call it precancer. I can't call it MGUS because they've had cancer and gotten treatment for cancer, but those patients I observe. And it's going to be really hard in coming years as MRD becomes more and more routine. We're going to have this natural pre-inclination to say, look, I want my patients to achieve MRD negativity. I also want that for my patients, but you have to ask, is the juice worth the squeeze when you start talking about other therapies to quote unquote force MRD negativity, right? Because it may be for some patients that MRD positivity is not that big of a deal, and really the devil's in the details.
So it's obviously complex from many points of view, but let's take the patient's perspective now. So the patient says to you, you find that they're less than 10 to the minus fourth or 10 to the minus fifth, but they're positive with an assay that shows it to 10 when measuring to the minus 6 or any variant of that. And the patient says, well, Dr. Banerjee, am I in remission or not?
Agreed.
But, am I going to relapse? Am I going to die of this?
It really depends on the malignancy, which is hard. Yeah, I would say in leukemia, in acute leukemia, and I don't treat it anymore, but for those patients, I know MRD negativity is absolutely a goal worth fighting for. And for example, blinatumomab is often used, which is a B cell, which is a CD19 specific antibody or T cell engager, is used to flip people from MRD positive to negative. In multiple myeloma, for example, I counsel them that, look, MRD negativity, and we'll talk about this, I'm sure, in a bit, is helpful in studies. And in studies, patients who achieve MRD negativity on average do better than those who have not. But that doesn't always apply to the patient sitting in front of me. And again, I have had patients who are MRD positive who are fine with it. And I think the big question you have to ask yourself as you're checking MRD is, what are you going to do with this information? If it's purely for prognostication, that's okay, right? I'm not saying it should not be done for prognostication. Some patients want to know, but I think when you check it, you have to know what first rule of medicine, will this test change my management? I think worth discussing, how will it? And sometimes in myeloma, for example, MRD guided decision points are being used primarily for de-escalation of therapy. Myeloma, in some ways, we have it easy because patients are used to being a treatment forever. That is the default you're starting with. And so you can use MRD negativity, what we call sustained MRD negativity, to kind of pluck patients off of it. And so if they're MRD negative on two different checks, I can say, oh, maybe you can stop your lenalidomide. Maybe you can stop the daratumumab on a case-by-case basis. And so the default is stay on treatment. So the patients who remain MRD positive, it's not wildly out of the realm of possibility for them to stay on treatment. For other cancers, again, we sometimes change treatment based on MRD positivity, blinatumomab and BAL being the big example. And that's a bigger decision, right? In myeloma, we're not there yet. In CLL, we're not quite there yet, right? For a drug like ibrutinib, the status quo is treatment basically for forever. And if they're MRD negative on ibrutinib plus venetoclax, it's nice to be able to stop them, but you're not escalating them. You're just either maintaining or de-escalating. I would say that those discussions with patients, I think, are reasonable to say, look, your prognosis may be poorer, but in any case, I'm not going to stop your treatment. We'll keep you on treatment. If you're planning to change something based on MRD positivity, that's a tougher discussion. And that probably is for the patient where you know that MRD positivity portends poorer outcomes. You need to do something about it.
Got it. Your example of, let me see if I'm summarizing correctly, a patient with myeloma who after treatment sort of goes back to an MGUS status. What would you do with that patient based on either the clinical scenario or the finding that the clone is still there?
It's a great question. Yeah, so it's really tough, basically. We're still trying to learn about this MGUS-like phenotype and what to do with these patients. In brief, I don't de-escalate them, because even if these cells have been behaving for 6 years after transplant, for example, we know from MGUS that MGUS doesn't normally behave, but sometimes doesn't behave on the other side of the cancer journey. And so I typically say for those patients, I would generally not stop all treatment entirely. I would say that at least in myeloma, to stop all treatment entirely and to even use a cure word for someone, I typically would need to see MRD negativity. But for MRD positivity, yeah, I think the biggest thing I do is reassure them because, again, people have looked at this. There was a British study looking at patient perceptions before and after their bone marrow biopsy for myeloma, and it was night and day. You could see that the patients who achieved MRD negativity, the words they used to describe the results seeing it were like positive, hopeful, optimistic, and the ones who were MRD positive were like let down, disappointed, fearful, etc. And so I think for those patients, whenever I check MRD, and honestly, I joke about this to patients, but it's very real. I tell them that, look, if a patient comes to me and says, I want to check MRD, it's almost like buying a firearm. They have to have a waiting period. I give them a waiting period. I was like, okay, let me talk about it first, how, this may
Yes.
not or may change your management. Think about it, come back to me. If you still want to check it, we'll do the bone marrow biopsy and check it. But just to talk it
Yeah.
through, because for some patients, it's really hard for them. They're MRD positive. They want to be negative. And I can reassure them that, look, you're fine. As long as these cells are not causing bone fractures or kidney damage, I'm fine with them. But it's hard for some patients to process. So I just have that discussion with them first that in
Yeah.
most
Yeah.
cancers in 2025, MRD is not yet changing clinical management. In the future, that may change. But for now, I think it's a discussion that MRD positivity in most cancers right now is not a death sentence.
So years ago, and this is an older example, but in breast cancer, we used to do tumor markers and do them every 3 months. And if the CA2729 was 38 instead of 36, we would often embark on a very big workup with CAT scans and bone scans, et cetera. And it ended up not impacting survival.
Correct.
Yeah, some of it was lead time bias, et cetera. So we weren't helping those women. What's your gut feeling on this? We've talked about being able to find it and maybe changing therapy based on it, de-escalating, escalating. Let's talk about a few diseases, but is your sense that it will impact or does impact on survival?
So I think obviously it depends. I think in clinical trials, for example, absolutely. And at least in myeloma, that has been shown. The idea being, I describe it to patients as like the voltage of an intervention. If you test 4 drugs versus 3 drugs, and the voltage of the 4 drugs flips this X% more patients to MRD negative would have been positive. Studies have shown that the bigger that voltage, the bigger advantage in progression-free survival and overall survival you see. For individual patients, it's trickier, again, because we're not looking at 100 patients, looking at one patient, unique disease biology, et cetera. I think that being said, eventually with enough patients and with the right tools, that if you're achieving MRD negativity is actually sustainable and sustained MRD negativity, I think you will see a benefit in survival down the line. The idea being is that just by laws of physics alone, right? Even if, to your point, there is some disease left, but it's underneath this threshold we set, 1 out of a million. If you just assume that cells double at whatever rate they double, the patient who goes to transplant in myeloma and ends with 1 out of 100,000 cells as their baseline versus the patient who ends at 1 out of 100 million cells as their post-transplant baseline, that latter patient will have many more months and years to get to a point where the myeloma comes back and has to require different treatment. And for all I know, that actually might lead to prolonged survival for those patients. And so I think the principle is there. I think the hard part is different drugs achieve MRD negativity in different ways. And that's one of the hard parts of trying to compare between studies. After transplant, when someone achieves MRD negativity after auto transplant, it's often a function of just chemo. Chemo did the heavy lifting, great. Same for R-CHOP and lymphoma, et cetera. With allotransplant or with CAR T therapy, I think it's a different matter entirely, because that's just not chemo trying to get into every door that it can. That is an immune cell, a T cell, whether it's an allotransplant T cell or a CAR T cell, physically going door to door to door, eliminating everything it can see. So I would say that after CAR T therapy, that MRD negativity actually probably does mean prolonged survival, versus with transplant, maybe not so much, versus, again, chemo, auto transplant, but it's tricky. I think we'll need more studies to tell.
If you were advising, and you probably are, but clinical trials, and we can start with myeloma, but in the clinical trials, how do you think MRD should be used?
So I think it absolutely should be measured. And so what I would say to anyone listening to this from our partners in industry, I think MRD negativity absolutely should be measured by whatever test you have available. Our line in the sand as the myeloma field, we insist that you should always report MRD negativity as an intent to treat. Otherwise, it's misleading to patients. What do I mean by that? We've all seen trials and across cancers where they say, look, 90% of evaluable patients achieved MRD negativity, but you set the criteria so stringently, have many patients who were in remission, had a bone marrow biopsy checked, had everything ready. What about all the patients? You know what I mean? So if you say 8 patients achieved MRD negativity, the denominator should be everybody on their trial, if that makes sense. So that's in terms of reporting. In terms of what do you do with it, I think it actually has a lot of potential. Myeloma is, again, kind of leading the charge here because we had an ODAC, an FDA drug advisory committee last year that unanimously said that MRD negativity should be used for accelerated drug approval. Accelerated drug approval is often reserved for studies looking at response rates or things that we know don't necessarily mean that much to patients down the line, right? MRD negativity in itself is not a huge deal for patients. It's the implications of it down the line. The reason it matters in myeloma and increasingly in other cancers is as our treatments get better and better and better, to draw a distinction between 4 drugs versus 3 drugs, if you had to wait to see a progression-free survival or a disease-free survival benefit, that would take years to get there.
Years, yeah.
MRD negativity gives you a shorter readout. There was a study in myeloma, just to give one example, the benefit study, not a registrational study, but just a good example of 4 drugs versus 3 drugs in myeloma. And they powered it to MRD negativity. And they indeed found that at 18 months, the 4-drug regimen had much higher, almost double the rates of MRD negativity compared to 3 drugs. That's changed my practice. I talk to patients about it. I tell them that, look, we don't know yet, as of the data cut this year, if it prolongs survival. It'll take us another 6 years to find out, but it probably will based on what I'm seeing. And I've used that in my practice. And so I think it's really helpful in that regard. Obviously, that would be a scenario where even if the patient isn't checking MRD themselves, the use of MRD in trials to give me an early readout to what these drugs are doing is informing my practice for the patient in front of me. So that's a good example where the use of MRD in trials can help patients across the country, across the world, even if you're not checking MRD routinely. But again, I would say whatever you're doing with MRD, report it accurately would be my biggest advice to clinical trials.
For patients who are treated in the community, again, nuts and bolts. How is testing done? Where is it done? Is insurance covering it?
It's a great question. So it's tricky. I will say that I think more and more insurance companies are realizing the value of this. And at least in multiple myeloma, the assay we normally use, this NGS assay, actually is FDA cleared. And so I've only had a handful of rejections and I've appealed it every time. I think the biggest thing will be partnering with your lab and making it very easy to do. We need to partner with our colleagues in hematopathology because they're the ones who see the bone marrow sample or the blood sample in laboratory medicine and roll with it. They need to have an ironclad partnership with the vendor, be that flow cytometry at the Mayo Clinic or next generation sequencing here in Seattle, et cetera. I think that would be the biggest part. So for community oncologists who are interested or patients are asking, talk to your lab first and talk to someone on the phone and find the champion in that lab because you need that. Otherwise, it's like pulling teeth if the lab doesn't know what they're doing. The other part will have to be to educate, again, in myeloma and leukemia, typically MRD is a check off the bone marrow. It has to be first pull. The idea being is that when you do a bone marrow aspirate, that first 2 to 3 milliliters of bone marrow aspirate, that should be the one to check for MRD. Use everything else afterwards. Because, as we've talked about, MRD is all about the denominators. Measurable residual disease, the number is predisposed on how many cells you identified.
Yes,
and if you wait till the very end, you start getting blood basically getting diluted into the sample, and that can completely make the MRD value meaningless. So I would say if you're interested in doing, I would encourage it because I think patients are asking about it. As I've talked about, I think it does have real value. I would say talk to your nurse practitioners or nurses who are doing it. If you're doing it, same principle as well in terms of, again, first pull should be the one being sent for MRD, and then talk to your lab because I think I'm lucky. I work at a large institution, and our lab has made it idiot proof. By idiot, I mean me, the doctor, ordering it. They make it very straightforward. If I do a bone marrow biopsy, they have a pathway they follow. And if they know that it's multiple myeloma and they see that it's below a certain threshold, they will check it. It doesn't even have to be MRD negative. It's still helpful in some cases, even if it's quantitatively a certain number versus not, they will send it. And they will take care of the insurance process accordingly. And I will say that, in 2025, it has been much smoother sailing. And then maybe the insurance companies, then maybe the vendors that make these tests being kind and not trying to balance bill patients. But either way, I have not gotten many complaints at all.
Yeah, terrific. So, Rahul, I want to ask you a question that really intrigues me. But let's take a patient with myeloma who had, let's say, a large M spike and 70% plasma cells, and I treat them, you treat them, and they go into remission. Let's say their M spike is gone. What is the sensitivity of all the different tests, the M spike, the kappa lambda, the bone marrow biopsy, the NGS, to finding measurable residual disease?
For outcomes? It's an excellent question. And it's one in the myeloma field we actually debate about a lot. And it's maybe relevant to other cancers as well, but this is a little bit more similar to myeloma because in myeloma, as you're alluding to, one of the only cancers besides prostate cancer and choriocarcinoma where instead of checking for the cells, you check for the protein that they produce. In brief, the deeper the level of traditional response, partial response, very good partial response, complete response, the higher the odds of achieving MRD negativity. If you achieve MRD negativity, on the other hand, your serologic response doesn't matter at all. So to put it another way, basically CR, VGPR, PR, and myeloma are just surrogates for MRD negativity. If that sounds really weird to say, it is weird to say, but that's actually very true. That by virtue of having achieved a complete response, correct. And so by virtue of having achieved a complete response, let's say, depending on what drug regimen you got, because again, CAR T is very different from traditional treatment. Let's say probably like a 50-50, I would say, depending on scenario, for a complete response being MRD negative versus positive. For a very good partial response, maybe more like 30% odds of being MRD negative, because someone's N spike is 0.1. It may just be that it takes time to clear, but they're actually MRD negative in the marrow. MRD negativity is MRD negativity. So if you then look at those patients who are MRD negative, they do excellently. The Kaplan-Meier curves are well above everybody else. If you're MRD positive, whether you're a complete response, very good partial response, minimal response, no bearing on anything. Those patients do equally poorly in comparison to MRD negativity. One of our myeloma colleagues in Spain, Dr. Bruno Paiva, he's led a lot of this work with various Spanish studies showing this. And so there may be a time in the future where that's really all that matters. MRD negativity, the only reason that the conventional M spike matters is just kind of a ballpark of when to check for MRD. So you don't check it too early, but that's the MRD negativity that matters. It's obviously in other cancers, there's not that much of a two-part way of assessing things, but that's what I would say, that at least in myeloma, MRD negativity is all that matters. Possibly in leukemia, sometimes we talk about checking peripheral blood flow, but the same principle, MRD is all that matters. In CLL, generally speaking, blood MRD tends to match bone marrow MRD. The bone marrow may be, from what I've heard, slightly better in some scenarios. So that might be a scenario where the blood is a good starting point to what's in the bone marrow. Bone marrow is going to remain the gold standard. And so I would say that the benefit, I'm not saying don't check an M spike, obviously. It's a little helpful to just get a quick barometer of what's going on. And obviously, if someone's M spike is still 0.5, that doesn't make sense to check for MRD negativity then. I typically say, for myeloma in particular, if someone's achieved a very good partial response, a 90% reduction in the M spike or light chains are normal, M spike is approaching 0.1, that's actually a very reasonable time to check for MRD. After CAR T, for example, therapy, most of my patients are MRD negative at day 28. Very few of them are in a complete response. So very few in remission because the AM spike takes months to clear out. CAR T works like that. And so day 28, bone marrow is clear, prognosis excellent. The AM spike sometimes takes a year to clear out, and I'm okay with that just to counsel patients. It's weird because they'll ask, am I in remission? By the book, they're not in remission because the AM spike's not zero, yada, yada. But in my heart, they're going to do great.
Terrific. And it really is a different paradigm.
It is.
So thank you. The last thing I wanted to ask you was about resources. What are some good resources for patients? And then also, if you have any for clinicians.
Yeah, that's a great question. I think for your colleagues, I think the biggest thing I can do is obviously the studies help, but I think the biggest thing in terms of how to use MRD and how to check MRD would be to partner with your colleagues at academic sites or large centers, just because we've gone through this rigmarole before in terms of how does our lab handle it? What do we tell our technicians and our nurse practitioners who are doing the bone marrow biopsies if they're doing it and not the physician, et cetera, is helpful. And I think in particular for myeloma and CLL and a lot of these cancers, the MRD role is constantly evolving. Every conference I go to, something is changing about how to use MRD and what imaging do you need to back it up with, how many years are you waiting to check it, what do you do with it, et cetera. So I actually think the best tool would be just phone a friend because this is constantly evolving. We'll be able to help kind of provide some additional nuances. For patients, I think Blood Cancer United has a very nice guide to give to patients about this. I think doctors and nurses at the center obviously are quite helpful. Those are probably the biggest sources that I would say of help. And I always encourage my patients to join a patient support group, because a lot of times the patient support groups are where you actually learn from other patients how they've navigated. It's just hearing how another patient has used MRD negativity or not used it might be helpful to tell you as you're thinking about, should I be checking for this as a patient or doing anything with it if it is checked?
Yeah, very good. Thank you. So again, this is Dr. Ken Miller. This has been a really interesting episode talking about measurable residual disease. Anyways, with all that in mind, we've been with Dr. Rahul Banerjee, who's an assistant professor at the Fred Hutchinson Cancer Center in Seattle. Rahul, thanks for being with us.
Thank you, Ken, for your time, and thank you all for listening.
And I want to thank everyone for listening to this terrific episode. For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, including a fact sheet on MRD, please visit bloodcancerunited.org/CE. For any questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. Blood Cancer United also provides other resources for patients, survivors, and their families, and that can be found at bloodcancerunited.org/support. And I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.